from the purpose of having some tips. नहीं हम वेट कर रहे हैं, हम तो खत्म कर देंगे. So TIPS, new session TIPS, T stands for tips, I for in and practice. So aim of this session was that every time we meet, this is a new session actually we are starting. We will have a combination of anterior segment and posterior segment because anybody can have any kind of patient. So all of us should have at least few initial tips, whether you are do retina or not, or whether you do anterior segment or not, in the management of each other's specialty also. So we will wait for these anterior segment people who are busy always everywhere. So Rajesh Sinha is not here. Then Dr. Harbanslal, past president, is also not here. But in any case, we will still move on because time is of utmost importance. So one of the situation for all cataract surgeon is about the PCR. PCR is a nightmare, but if well managed, believe me, results are pretty good. So our job will not be to cover the entire PCR or the entire topic. Our job will be to have some tips so that you can recognize PCR and how to do a vitrectomy in PCR if vitreous has come out. So we have with us Dr. Avnindra Gupta, who is a senior consultant at Center for Sight, plus he has his own practice in Faridabad. He is a high volume surgeon, does a lot of posterior segment surgeries. So he will just give you tips in how to, if you have a PCR and if there is a vitreous there, what are the tips in anterior vitrectomy? Yes, Mike.
For giving me this opportunity of speaking on anterior vitrectomy. It will be a more practical oriented talk and most of it will consist of videos. Posterior capsule preservation is the most important step in management of cataract surgery for completion of surgery and for implantation of intraocular lens. PCR is usually associated with vitreous loss. Vitreous management is key to cortex removal and IOL placement. Good vitreous management lead to decreased post-operative inflammation. Many times you will have vitreous prolapse into the anterior segment. This will cause decentration of IOL. The pupil will be distorted and patient will keep on complaining of glare. There is a decreased posterior segment complication if you do a good vitrectomy like CME and retinal detachment. Maintenance of anterior chamber throughout the management of the posterior capsular rent and anterior vitrectomy is of prime importance to prevent any kind of complication. What should you do? Cortex and vitreous is restricted to anterior chamber. First, use viscoelastic to stabilize the AC and push the vitreous behind. Your flow rate should be decreased and to decrease the turbulence, because more the turbulence, more the vitreous will come. Combine vitrectomy and aspiration of cortex. Place the IOL over the rhexis, and usually it should be a 3-piece IOL. Before going for anterior vitrectomy, most of us should know our phaco machine and how to attach a vitrector. Because for an anterior segment surgeon, PCR is an emergency situation because he knows कि लेंस अब पेशेंट को जवाब क्या देना है कल, अब लेंस डाल पाएंगे कि नहीं डाल पाएंगे, कॉर्टेक्स रिमूव कर पाएंगे कि नहीं कर पाएंगे. So he should, and the attendant or your OT technician should be well versed with the machine. So if you are going to another center, a dry run should always be done. There should be an availability of good cutter, and vitrectomy should be done in a closed wound. It should be a closed chamber. It shouldn't be an open chamber. So if you are doing an ECC also, put sutures. If it is a phacoemulsification, do from 2 paracentesis. It should have high cut rate and low suction. Use paracentesis for bimanual vitrectomy. Mouth of the cutter should be towards you, and it should not be facing towards the iris or the posterior capsule, because the cutter is so fast, moment it sucks the iris, it's just a fraction of a second, it will cut your iris. So it should be always towards you and away from the iris. Be away from the iris and capsule, as you can damage both. Lot of videos you must have seen ki you put tricot, but if you put tricot without an IOL, the tricot will precipitate into the mid-vitreous cavity and you will be unable to remove this tricot. So tricot should be put after the IOL is placed. This is one thing what I wanted to say. In normal machine, what happens, the paddle 1 you see infusion, paddle 2 cutting comes, and paddle 3 aspiration. So in Alcon machine, or if your machine can go on to this setting, that is paddle 1 is infusion, paddle 2 aspiration, and paddle 3 is cutting. So what the advantage of this position is, at paddle 2 infusion is on and aspiration is on. So your cutter works as an IA system, it works as a bimanual IA system. The moment the vitreous comes, shift on to paddle 3, do some vitrectomy, and again shift on to paddle 2, it works as an IA and you can remove the cortex. So frequent change of instrumentation is not there if you put this second setting into your vitrectomy machine. If you have any nucleus or the nucleus fragment, it will not come with the cutter. You have to remove this either with a fragmentome or with a phacoprobe, or you have to do a visco expression of this nucleus fragment, because these are hard and you cannot cut this. Once the visco expression is done, the lens is placed and you then do a vitrectomy. You can see the port is towards you, the visco is removed. You go on the side with two, it's usually bimanual from the side port. You go on the side of the iris. If there is any vitreous, just remove it. Put an air bubble. If you get a single air bubble, it's a classic teaching that there is no vitreous. Then you can see here, I'm doing a bimanual aspiration. There is a big rent here. You can see there is a rent, and every time you go for a bimanual, this vitreous comes into your aspiration port and it blocks it, so you are not able to aspirate the cortex. So what I do is I go ahead with a cutter. You can see this is a cutter here. You have to go at the plane of the posterior capsular rent. Ideal is not to go from the main wound, go from both the side ports. Go from both the side ports, cut the go from both the side port, cut the vitreous, and then remove the last bit of cortex. And believe me, if you have done a good vitrectomy, remove cortex, then it is as normal as without a rent. Only two things you have to manage. Post-operatively, these patients will do very well. 3-piece lens is placed over the rexus, and day 1, this patient was doing pretty fine. This is another patient. You can see here, it's an opaque IOL. What we do here is we create a space between the rexus. We try to pull the lens, but the lens is stuck. There is a capsular lens adhesion. Whole of the bag is coming out. So at this stage, we decide to cut this lens and then remove this lens. Now there is a posterior capsular support available. The lens is explanted, and once we explant the lens, you can see already the AIOC capsulotomy has been done in this patient. There is a big posterior capsular rent, and we place the IOL over the fibrosed capsule and put tricot. Other thing is, if you are not comfortable with a bimanual system, you can put an AC maintainer kind of a thing, what you have put here. From one of the paracenteses, you can put an AC maintainer. There is a continuous flow of fluid, and the chamber is maintained. And once you do this, you can do a nice vitrectomy, close the wound, and the vitreous is taken care. In this patient, we have done a refractive exchange. So since that capsule is deficient, and I expect I won't be able to place the lens over the deficient capsule, so we are also planning for glued scleral fixated IOL. So I have placed an trocar cannula system here that if I have to do a SF IOL, I will be able to do with this trocar cannula system. The lens is removed. The three-piece lens is placed over the rhexis margins which are available. It is dialed. You can see the lens is stable, so we didn't require a glued SF IOL. You can see a lot of pigment is there, a lot of vitreous has come because the capsule is deficient. So what we do, we put on the infusion into this cannula system and start doing a vitrectomy here. And I go on the besides the margins of the lens, cut all the vitreous, remove all the pigments. At this stage, I realize I have not done a good vitrectomy, and there are a lot of pigments here in the vitreous posterior to the lens. So I change the infusion, make this as an AC maintainer. I use this port to do an pars plana kind of an anterior vitrectomy, which is pretty easy to do and very conclusive because you are pulling the vitreous from behind and it doesn't comes into the anterior chamber. You can see all the vitreous opacities has been removed. The media is absolutely clear, and this patient had a very good visual recovery without any floaters. This is one of the patients who had needle stick injury. We did an ultrasound for this patient. There was a pre-existing posterior capsular rent. The age of the patient was somewhere around 20 years. So I said to my anterior segment surgeon, he said it's just cortex aspiration. But I said, you will land up into a problem, so I have already placed a trocar cannula system. He's doing an irrigation aspiration of the cortex. After doing 10 minutes, he's stuck because it's mixed with, cortex is mixed with vitreous. You can see he's trying to manipulate, but it's not helping him. The cortex doesn't come. So what I do, I go from behind. I just make another port and do a vitrectomy within cortex aspiration. I am not doing a 3-port vitrectomy. The concept, what I told you earlier, is that you cut the vitreous, put the cutter off. Now this works as an IA system. So here you can see I am going between the capsule, and I am just using I am not using the cutter here because the moment I cut the cutter, I lose the capsule. I am using this as an IA. The fluid is coming from here, and this works as an IA, but it's from the pars plana. So you can see how nicely I am able to remove whole of the cortex, and the cortex is removed. The moment the vitreous comes, you shift on to the vitrectomy mode, cut the vitreous, and again put off the cutter. Like this, whole of the cortex is removed, and I have also preserved the capsule which is available. And this capsule helps me to place an lens over this over the rhexis, and now I am putting a 3-piece lens, and this patient improved to 6/6 vision. To conclude, PCR and vitreous loss is inevitable part of phacoemulsification surgery or cataract surgery. Managing complication the right way makes you a good surgeon. 90% of your cases will be fine, but whosoever manages this complication is the best surgeon. Do not rush into putting IOL. Do a good anterior vitrectomy and cortex removal. which prevents a lot of post-operative problem. And if you do this, your patient will be as normal. You can even put any kind of IOL, the lens will be centered. And lastly, knowing your machine prevents intraoperative palpitation. So don't say once the rent occurs, then you ask your technician, bring the cutter, bring this, bring that. It's a chaos. Everything should be quiet and should work like a music once you have a complication. Thank you very much for your kind attention.
Thank you, Avnindra, for this multiple tips. Anybody has any question to ask, feel free, because the name of the session itself is tips. Otherwise, I'll make a couple of comments. Yeah, anybody? So, very good suggestion was that tricot should be placed after you have done the IUL, after you have put, because otherwise tricot may percolate and you may have to, although it's not a disaster if it goes behind, because it will in any case help in inflammation. But that's better. Second point was about, Avninder, you showed both the kinds of vitrectomy, anterior as well as posterior, because a lot of us advocate vitrectomy from the pars plana, because if you cut vitreous from behind, vis-a-vis if you come from anterior segment, then the vitreous behind will have, propensity to come anteriorly. So what do you advocate?
Ideal situation is you should be doing vitrectomy from the pars plana. What happens if you do from the anterior segment, the fluid goes behind, it hydrates the vitreous, and more and more vitreous comes. More vitreous comes, it tends to extend the posterior capsular rent, and you have to work near the lens, so capsule and the iris, and many times you can cause an extension of the posterior capsular rent. If you have a posterior capsular rent, if you can maintain the size of the rent, that is the success of the surgeon at the moment. If you do from behind, you are pulling the vitreous into the vitreous cavity. You are going into the enemy's territory, and here the enemy is vitreous, and you are going into enemy's territory, that is vitreous cavity, and attacking it there. So once you are attacking it there, the results are much better as compared to anterior. But mind you, all anterior segment surgeon has a fear of entering through pars plana. That fear has to go out from the mind, and you should have a trocar cannula system and a good 23 gauge.
Believe me, this point has been emphasized, but fear still exists.
I think more than fear, actually, the anterior segment surgeon's list is so heavy, and though it may be notional for 3, 4, 5 minutes, but somehow or the other it gets there into their mind that you now remove the phaco probe, put on a vitrectomy cutter, go from here. So I think because they probably, because most of them will be having 10, 20 cases lying behind. So some of the centers actually advise if there's a PCR, don't move any further and post it some other day, so that you have to relax time and do whatever you want to do.
The other point I wanted to make was about once the vitreous is mixed with the cortical matter, because a lot of people still keep aspirating. That is not good. But that is the time to put suture and have an automated instrument like cutter, because that will cut the vitreous as well as cortex. Because if you keep aspirating vitreous with cortex, that will never come out. And the third point I think I wanted to emphasize was a working cutter, because once you are doing a vitrectomy, often you don't see the vitreous, because vitreous is a clear kind of gel. You may not see the vitreous. So you are doing tick, and vitreous you may not be cutting, because vitreous is not visible. So sometimes to make vitreous visible, you inject 1 or 2 drops of tricot to make vitreous visible. So otherwise vitreous may not be visible. And if you, because the PCR rates are not very high unless you are in the initial stage of your career. So a cutter should be good, because sometimes if you take an old cutter left over by somebody else, it is not working. This cutter will suck more and cut less. So that is not done.
Is there any way to find out whether cutter is working or not?
No, you actually...
No, because you are right. I mean, if the Alcon is charging some 25,000 for a kit and you are charging, say, 30, 40,000 for a cataract, and the PCR happens, and you open a 25,000 kit will be, I think, very, very difficult for us to really digest that you'll open a 25,000.
Sometimes these old cutters may be jammed, because you open it so
No, I got
early.
a point, but besides the movement which you can see on a water, a ball, whether the cutter is moving to and fro
Surgeon
or
is
not.
thinking that he is
But
actually
you can see
cutting.
the vitreous fibrils, and many times if you can't see, you can use an indo illuminator to see it.
No,
And
cutter
what-
movement is there, that you can check with before entering inside the eye, whether the tip is moving or not, that you can check. But whether it's a cutting or not,
Yeah.
is there some tissue to cut it before you cut the vitreous or something? Something like we do the iodectomy or something. I mean, there should be some maybe artificial material. You can check it whether it's a cutting is all right or not. Because for anterior segment surgeon to open a new set every time he has got a PCR will be probably not very cost
A
effective.
single cutter you can use for at least 8 to 10 times. But you should not be using that cutter indefinitely. That is the thing.
No, not indifferent. Actually, like he was saying,
the
because
reason-
many a times the anterior surgeons, the OT technician also not very well trained to clean the cutter properly. So when you use first time, it may be actually, get second time may not be in a very good shape.
So
very
that's
good
what
shape.
if I told in my talk before, you should be well versed with your machine, the cutter, and the technician should be well versed in putting that. It should work as a music. It should not be an emergency condition in the.
So your eye should be looking at a vitreous fibril, because if it's a vitreous fibril which is organized, you will see the movement of cutting, or the cortex. Suppose there is some cortical matter, so you'll see the cortical matter getting cut and aspirated. Short of that, if it's absolutely clear, there's no only vitreous. Sometimes it's difficult to see, so I'll put 1 or 2 drops of tricot. That will make it 100% seen whether vitreous is there or not. That will make it 100% visible. Because doing a blind vitrectomy vis-a-vis a visualized vitrectomy is better. Okay, now, yeah, Punita.
Vitrectomy, like anterior vitrectomy, because the vitreous is mixed with the cortex matter. So you can easily cut the iris and go behind and damage the cerebral body. How to prevent that?
And that's what I showed in my video. You can cut away from the iris. The cutter should be towards you and not towards the iris. And the system, what you first as paddle 1 aspiration in fluid, paddle 2 is aspiration, and 3 is cutting. So the moment the vitreous is not there, you can work with that cutter as an IA system. And the moment the vitreous comes, you go to the cutter mode, remove the vitreous, and again keep on working on IA mode. Last 2 cases were like that only, and I was able to preserve the capsule, remove all the cortex, and place the IOL over the remnant capsule.
Okay, we'll move on. We have with us Dr. Harbans Lal, and his practical tips. If you read his book, which was written more than a decade back on cataract surgery, you actually feel that you are doing a surgery and getting some tips. So therefore, I called him to tell us how to recognize. Sometimes you may not be able to recognize also, but PCR has happened. Yes, Harbans.
So signs indicating the PCR, first of all, we should always have a very high level of suspicion. I mean, anything which is not going according to the plan, whatever may be the step of surgery, you must suspect that there is a PCR. So in that case, like localized bright red glow, anywhere suddenly you see a bright red glow and you were not expecting, that means there's something wrong. Irregular anterior chamber depth, non-rotation or difficult rotation of the nucleus. You try to rotate, it comes back. You try to rotate, it comes back. Even if you should not attempt if it is not rotating. Even not because of PCR, because of any other reason, whether the hydro was not complete, whether the jonules are weak, whether the PC is lax. So there may be many situations where the nucleus may not rotate, but if it is not rotating, please don't force it to rotate, whether it is because of the PCR or not. The tilting of the nucleus, and pupillary snaps, and when do hydro and suddenly pupil gets dilated and bright red reflex. So there may be, normally, the way normally you do the surgery is going, everything is smoothly, you rotate, the nucleus rotates, everything is fine, it's okay, but anything you find unusual, suspect the PCR. Many times I have seen, I do the hydro, I see a line behind in the posterior capsule. Then I think whether it's a PCR. And then I found out that it was because of the very lax posterior capsule, because of the lax jonules, the posterior capsule was floppy, so I can see it was a fold on the posterior capsule. It was actually not a PCR. But I took all the precautions as if it is a PCR. So anytime you have got any doubt, that the chamber has become unusually deep, chamber has become unusually shallow, chamber is irregular, people gets dilated, people gets small. So something happening unusual, you should always have a high level of suspicion in your mind that there is something is wrong. And you can confirm if it is possible, rhexis margin tear extension, which they call as a flutter sign, whether it's true or not, and how much it is true that if the anterior rhexis margin gets extended to the posterior capsule, then the anterior capsule flaps will not be moving. But if it is only up to the anterior capsule, then they will keep on moving the anterior flaps. So that is called a flutter sign. Sweeping up iris fossa to look for the vitreous. Vitreous has got a tendency to come towards the incision. So that means if you go from the other side and put on an iris fossa close to the incision, try to sweep into the center, so you will see the tag of vitreous coming if it is there. So this you can do when you want to confirm the PCR. Also, when you are doing a vitrectomy, you are not so sure that you have done a complete vitrectomy and before you put on a tricot, because vitreous in the AC is not as dangerous as vitreous in the wound. So there should be no vitreous left in the incision. So you sweep it and bring it in. And tricot stitching is, of course, you should do a diluted tricot stitching, 1:4 or 1:2, not the full tricot stitching. And there is a halo test. I don't know, halo test is when you press the posterior capsule with a rounded depositor, you can see a light of halo coming from there. So the important thing in this halo test is that you should not put a lot of viscoelastic, because if the capsule is concave, you will not get a halo test. But if capsule is convex, then you press in the center, so then you will see the rim. So that means chamber has to be shallow to elicit the halo test. Otherwise, if the chamber is deep, you will not be able to elicit it. So the PCR may be visible, very clear, you have got no doubts about it. Now, like in this case, and suddenly you will see that the capsule has come, and so there is no confusion about it that the PCR is there. So there is absolutely, you know how to manage it. And the biggest mistake in attempt, we try to pressurize the anterior chamber, and because of the too much of injecting the viscoelastic, the capsule gets extended, as in this case. So you don't have to really pressurize, you just have to cover the coat and do not try to put too much of viscoelastic. Whenever there is a PCR, you try to put too much of viscoelastic, and if you can use the viscoat, that will be better. So in this case, then we bring, first thing is that you bring the nucleus out of the capsular fornices and place into the anterior chamber. Because if it is in the anterior chamber, it will not fall back. If it is the capsular fornices, if the PCR gets enlarged, it will fall back. And once it comes to the anterior chamber, now you can relax and plan what you want to do. So in this case, and whether you want to do the vitrectomy with the tricot, you want to put an IOL, so whatever may be your mode of management, but first you must ensure that vitreous is out of the bag. So we enlarge the incision, then with the two instruments we try to do the chopstick technique, try to crush and take it out, but then we thought it was not coming, got crushed. We what we call as a lens scaffold. Then you put the lens inside, and then after ensuring it, if you don't want to, you are not so sure, if you want to just pull it out by your this thing, and after that you can do the vitrectomy afterwards also. So if it is possible, if you are, and finally once you put the lens, you constrict the pupil, and now see with the tricot whether. So once, many times it may not be visible that PCR has taken place. So then in that case, you may have a doubt whether it's there or not. So you can see the red reflex over there, and iris is started coming, but now the red reflex moves as you move, so you think maybe it is purely epinuclear plate and the capsule is intact. So there's a little difficulty in rotation, but you can see that red reflex is moving along with. So surgeon has got some doubt that there's something is wrong. He is a little reluctant, you can see, in removing it, because he is not very sure whether the PCR is there or not. But you can see that the people have started constricting, and you can see now that there is a PCR. So he was not so sure and didn't take due precaution, and this rent now gets enlarged. A due precaution at that stage would have probably, and this patient had a multifocal IOL in one eye, and this eye has got a monofocal IOL. So I'm planning to now exchange the monofocal IOL with the multifocal IOL. And now this is the PCR, which was very small, has got enlarged because the surgeon was not so sure and didn't recognize on time. On the other hand, in this case, same situation, and this is now happening more in a soft cataract where it suddenly gets stuck. And as soon as we do, you can see the slight red reflex, a punch out over area over there, and whether there is a PCR or not, but you can see at the top of the screen, you can see the red area which is shining through and round spot over there. And this was a patient who had a cataract with small pupil. We put on a Malvin ring. So I cover this, rotate it, and you can see the punch out area rotates. But I was sure that there is a PCR. So we removed this, and you can see that the PCR, covered it again with this. Now I lifted that, the hole I created, I lifted that, and I'm not going into the area where the PCR is. I'm far away from the area where there could be potential vitreous. So just opposite, I have removed part of the epinucleus. Now my aim is to protect this vitreous, and I put on a viscoelastic behind. So lift the epinucleus. And after lifting the epinucleus, I'll put on a viscoelastic to push if there is a vitreous behind. And now this, you can see that this viscoelastic is going and will push the vitreous into the periphery. And I'll avoid any maneuver, any suction, anything on that corner. Ultimately, after removal, and we could safely put the synergy multifocal IOL in this patient. So high level of suspicion is very important. Anything unusual, you should take care. Thank you.
So, Harvansh, very useful videos, but two questions, although I'm not a cataract person, but the second last video you showed where epinucleus was being removed, although PCR was there. I would have shifted this to because all these machines of vitrectomy have, IA cutter. So you can, do that instead of allowing the vitreous to mix with the.
No, see the problem with the IA cutter is epinucleus plate is very difficult to cut with the IA cutter and takes very long. But cortical fibers you can hold and suck it, but epinuclear plate is very difficult to hold with anything, even with the phaco probe. And in this case, because if at all any vitreous was there, it was absolute and to the one corner. Another corner was absolutely free. And you have got to ensure that the vitreous has got a tendency to come towards the incision. If the vitreous has not come on that side, if you can do a lot of maneuvers on the side where the vitreous is not there. So we lifted the epinuclear plate and pushed the viscoat, which will stay behind the epinuclear plate. And even if there is a vitreous, some vitreous was there, it will push it into the extreme periphery. So on a low phaco emulsification parameter of a vacuum setting of 200 or 300, because now the epinucleus was already loose and has come onto the anterior part. So we did a whole of the suction, and on the other side where could have been potential vitreous.
And second question was in the presence of PCR multifocal IOL.
So that depends upon the size of the PCR. So in this, there was no chance of loop going into that stage. So no IOL, no loop was into that PCR. And we tried with doing little bit of vitrectomy over there, but there was hardly any. There was some vitreous tag over there. We stained with the tricot, and because the primary talk was on recognition, so I didn't show that. But there was a small tag of vitreous. After putting the lens, we actually used the cutter and constricted the pupil, so it was fine. And patient has 6/6 vision. So a small PCR. And you can put them in a toric area placed in patients of PCR. And if you have got a doubt, you can do what we call as a reverse optic capture. That means you can put the loop into the bag and take out the optics out of the bag. So that way, you can really seal perfectly all right, because the single-piece lenses are not supposed to be placed into the sulcus because of the iris chapping, and because the iris keeps on constricting can cause more inflammation. But they can be placed in the bag, and optic can be brought into the.
Okay, very useful tips. Anybody would like to differ or any questions from Dr. Harbanslal before we ask Rajesh Sinha to hear? So, Dr. Rajesh Sinha, Professor of Ophthalmology in RP Center, manages cornea and cataract refractive surgery. So, corneal ulcer is not an infrequent problem, frequently mismanaged. So Rajesh will tell us about the tips of management of corneal ulcer. Because as of today, I think no corneal ulcer should be allowed to perforate or lead into issues unless you mismanage. Rajesh.
Well, at the outset, I would like to thank Rajit Verma sir for having me in this interesting session that is on tips, and this is the term that has been coined by sir only, and I don't know whether it was discussed, but what tips means, tips in practice. So the basic idea is that we don't have to discuss too much of theory. We have to think about what are the practical tips that we take from this discussion, and would like to have your inputs as well. So the first thing is that, when you are getting a case of infectious keratitis or a microbial keratitis, so any infection, whether it's in the chest or it's in it's anywhere in the body, the most important thing is that you identify the organism. And it's the same case in corneal ulcer as well. Identification of organism is the aim of management. How will you identify the organism? Because you have to hit the organism with the appropriate antibiotic. So how will you identify? One is by clinical diagnostic clues. There are certain clinical diagnostic clues which gives you idea that probably this is the organism. Then some rapid investigative modality that will help you to know that what can be the organism. And of course, third is definitive, that is culture sensitivity, but it takes a lot of time. So the first two are many times practically very useful. So clinical diagnostic clues depends on what are the symptoms and signs. So the routine symptoms are redness, pain, sensitivity to light, and discharge. And if you get to see a case wherein there is a corneal ulcer which is localized with distinct borders, no surrounding edema in the cornea, it can be staphylococcus. And staphylococcus is the most common organism that causes corneal ulcer. If you have something like undermining leading edges, serpiginous borders, you have hypopyon, then you can think of pneumococcus species. If it's a fulminant greenish yellow discharge, rapidly proliferating ring ulcer, which is fast growing and progressing, then in that case, and plus if you have an ulcer infiltrate with surrounding edema, that is again suggestive towards Pseudomonas species with a history of use of contact lens. Then Moraxella species will mostly seen in diabetics, alcoholics, and you have these indolent ulcers which are oval-shaped, inferiorly located. Nocardia and mycobacteria can have cracked windshield appearance. Clostridium can have gas in the anterior chamber as well as in the stroma. In Neisseria, if there's infection by Neisseria, you get a wreath-like appearance. So all these things give you an idea what can be the organism, and then you can start your empirical treatment. Now, if there's a history of trauma with vegetative matter, then you can think in terms of fungal keratitis, particularly if somebody is having an indolent ulcer. The infiltrates have feathery margin. These are deep infiltrates, endothelial plaques, fixed hypopyon, then pigments on the ulcer, something like this, which can be seen in curvularia keratitis. So then a cotton wool kind of appearance, which is seen in candida keratitis. Then, so these things give you an idea that what can be the organism. Again, if somebody is a contact lens user and develops a keratitis, severe pain in the eye, then that can suggest towards acanthamoeba. Particularly if you have a ring infiltrate, something like this. this is a ring infiltrate, ring-shaped infiltrate. In such a case, and that person is giving a history of contact lens use, or sleeping while wearing contact lens, or swimming while using contact lens, with this ring ulcer, you can suspect two things. One is acanthamoeba, one is Pseudomonas. If it is fast growing, if it is rapidly progressing with surrounding edema, then it is Pseudomonas. And if it is a slow progressing, then it is acanthamoeba. So these are the two important features, two important organisms that can be seen with these ring infiltrates. And sometimes you can get scleritis in acanthamoeba keratitis, which is very commonly seen. Total epithelial defect, anterior chamber reaction. Earlier, we used to feel that it is viral, but over the last decade or so, people have come to know that it can be because of acanthamoeba. And if there is surrounding scleritis, scleral nodule causing atrophy of sclera, then it can be acanthamoeba. And viral keratitis can be considered if you have a dendritic pattern, something like this. You don't have to do any scraping, you don't have to do any investigation. Dendritic keratitis, this is a herpetic keratitis. Just give anti-viral treatment, it will take care of it. If it can be necrotizing keratitis, there can be, badly vascularized and sloughed up kind of appearance, or you can have an edema. Suddenly a patient develops coin-shaped edema or partial, Descemet's folds, partial corneal edema, and you check the sensation. Sensation is dull. The first thing that should come to your mind is herpetic keratitis. And if you have a subepithelial nummular infiltrates along with conjunctivitis, that can be adenoviral keratitis. So the basic idea is that large number of cases can be treated based on the clinical clues that you get from the appearance of the ulcer, based on the history of the patient. Then you start empirical treatment, and studies have shown that in 75% of cases, if the diagnostic clues are suggestive, then the empirical treatment is effective and you don't have to change the antibiotics. And if the response is there and the culture sensitivity is showing something else, then also you don't have to change the antibiotic, because the response is the key. So depending upon the response, if response is there, whatever be your investigative report, you continue with the same antibiotics, antifungals, etc. I'll just talk a little bit about special situations like post-LASIK keratitis. Why we should know that these can be the organisms? Because if somebody comes with a post-LASIK keratitis, the first thing that you should think about the organism can be atypical mycobacterium, Staphylococcus, Pseudomonas, polymicrobial. Now, Staphylococcus and Pseudomonas can be seen in the earlier phase. Suppose a patient has had undergone LASIK and develops a keratitis. 4 days later, you won't think of atypical mycobacterium. If it comes 10 days later, you will think of atypical mycobacterium. But if it comes 3 to 4 days later, you will think of Staphylococcus. If there is surrounding edema along with infiltrate is there, you have measured the size, but surrounding edema is there, immediately start suspecting Pseudomonas. So these are some of the diagnostic clues that helps you, because many times by the time you get the investigative report, the ulcer has progressed a lot. Again, post-intact keratitis, this is mostly seen, whatever reports are there, Staphylococcus has been commonly seen. Infection after CXL has been seen. Infection after corneal graft has been seen by gram-positive cocci. Post-DSEC or post-anterior laminar keratitis, if it is early, in nearly more than 90% of cases, the source is the donor tissue. Check the culture of the donor tissue, you will get the organism, and then you treat accordingly. And of course, in immunocompromised individuals, you can have polymicrobial keratitis and bullous keratopathy. Again, the local immunity is reduced, so then in that case, the flora and fauna in the ocular surface does that. Contact lens induced keratitis, very commonly seen, as I mentioned earlier. If you have a person who uses contact lens, has slept for 3 hours, got up, and then starts telling that there is redness in the eye, you examine the patient has infiltrates. Later on, next day, a couple of days, he shows ring infiltrate. If it's progressing fast, it is Pseudomonas. If it's progressing slowly, it is acanthamoeba. So the idea is, the tip here is that the cause of infection also gives clues about the microorganism. And once again, going back to the main aim of management is to find out the microorganism. So the approach of management will be a very good history, good examination and investigations. You have gram stain, KOH, you have bacterial cultures, you have PCRs, you have, for fungus, you have KOH wet mount, Sabrods, dextrose agar, everything is there. PCR, rapid PCR, Confo scan, everything is there. But the key is that if there is a corneal ulcer, if there is ulceration, if you just have to do one investigation, do KOH. Rule out fungus. If it is not there, it is bacterial. Because a viral keratitis will give typically, initially, it will give a typical appearance of dendritic keratitis or a geographic pattern, etc. So that you know. PCR is quite effective. Acanthamoeba, as I said, that you can do staining with calcofluor white and cultures. I will not go into all these. Confo scan is a useful tool to detect the cysts and the trophozoites in the cornea. So in vivo, you can detect cysts, double-walled cysts in the cornea. You can see here, these are double-walled cysts. And you can also see the in the basal epithelium, the trophozoites. So the point here is that if there is an ulcer or a dense infiltrate or a deep infiltrate, do KOH wet mount. If it is negative, think about bacterial keratitis. And then based on the appearance, which organism is there, you have to think about. Do a scraping. Now, regarding scraping, I would like to say that most of the times, many times, it is negative because of wrongly done scraping. Why? Because there is a tendency to just scrape the surface of the ulcer. You should first debride that. There's a lot of slough tissue on the surface. If you will take that, culture will be invariably negative. And if you have to scrape one part, scrape the margin, not the base. Because even after a little bit of debridement, you can still have some slough tissue in the base. But margin will definitely have the organism. So scrape the margin, that is very important. If you can do the base, that is also fine. As far as drug therapy is concerned, mostly for bacterial keratitis, we give combination therapy of cephalosporin and aminoglycoside. If the ulcer size is less than 2 millimeters, then you can go for a monotherapy of fluoroquinolone. If it is more than 2 millimeters, go for a combination therapy. Atypical organism, if you get, then accordingly you modify your antibiotic. Like atypical mycobacterium, you can give azithromycin, clarithromycin, amikacin. If you have any doubt, then amikacin is one drug which is very useful. It not only helps in atypical mycobacterium, it helps in nocardia, it helps in actinomyces, it helps in pseudomonas. So one thing you should remember, that if it's not a very clear-cut staphylococcus ulcer and you have doubt, instead of using a tobramycin, use amikacin. That will take care. Particularly if you have history of LASIK, etc., then it is very useful. One important point, if there is a post-LASIK keratitis, one important point is that you should do the flap amputation. That is very, very important, because unless you do flap amputation, it is not going to help. The ulcer is not going to heal. And if you have a post-LK or post-DSEC keratitis, remove the lenticule. And then you will not only get the organism, you will also get all these, you will manage to control the infection. Fungal keratitis, we have the topical antifungals. One thing I would like to emphasize here is that in fungal keratitis, debridement is very essential. Because we know if we get fungal, on KH wet mount, you get fungal hyphae. You will start the treatment, but it will not heal because of two reasons. One, because the fungal infiltrates are quite dense. And the drugs, antifungal drugs, do not penetrate that well. So debridement, frequent debridement is must. Not only just during scraping, but frequent debridement. And if it is inside, if it is deep infiltrate, you have to do a wash as well as give intracameral antifungals. So as you can see here, deep infiltrate, you just remove the hypopion and then wash it, give intracameral antifungals, and then you surround this part. If the infiltrate is deep, surround this part with intrastomal antifungals, and I'll just move fast, and that is it. In acanthamoeba, bigonide is the treatment of choice, PHMB or chlorhexidine, and if you have scleritis, you give systemic steroid. Mycophenolate is useful in scleritis. You give it in increasing dose. You don't just give it 1.5 gram BD immediately. You start with 500 gram BD, 500 milligram BD, then 1 gram BD, and then 1.5 gram BD. So that is the way it is given. If it's a hepatic keratitis, acyclovir is the treatment of choice in such a case. If a disciform keratitis, you have to give systemic acyclovir as well as topical steroid, hepatic endotheliitis, etc. ASOCT is a good tool to manage, to monitor these patients. As you can see here, that where there is a hepatic endotheliitis, this much is the thickness. You started the treatment. The thickness reduced, but you see the posterior translucency has not decreased that much. It is still there. This means the activity is still there. You have to keep giving steroid. And this is the end point. The reflection of every part of stroma is similar, and it is clear. So that is a good tool to handle. And I'll just move on. In adenoviral keratoconjunctivitis, just a word about it. If there are subepithelial nummular infiltrates in the center of the cornea, then you should give steroid if the visual acuity is reduced, because it will not go off without steroid. If it's in the periphery, there's no need to give steroid. But if it's in the center, causing reduction in visual acuity, give topical steroid. Along with that, give topical cyclosporin. You can taper off the steroid because there's a risk of recurrence. You can carry on with topical cyclosporin. And the last thing is microsporidia keratitis. We used to feel that it's more often seen in coastal region, but now we are getting a lot of such cases in Delhi and North, in other parts as well. Many treatment modalities have been tried, like fluoroquinolones, voriconazole, etc. The best thing is when it gives you a stuck-on appearance on the cornea, like something is stuck, just debride that and put the patient on a little bit of fluoroquinolone, and that will be useful. And if medical therapy fails, you have to do surgical management. Small perforation like this or an impending perforation, you can put glue. A little larger perforation in the periphery, you can put patch graft. I will skip the video for paucity of time. And a larger perforation and a central perforation, you do a tectonic graft like this. So the tips to manage corneal ulcer is rapidity. That is the most important thing. It's an urgency. It's an ophthalmic ocular emergency. We have to be very fast. Identification of organism is the key, because that is what we have to treat. We have to kill the organism, kill the bug. We can get clues from clinical diagnostic clues or by investigations. Proper scraping again is very important. Don't keep the slough tissue for evaluation. Remove that first, debride it, and then do it. And daily documentation is very important, because many times subjectivity does not help in managing these cases. Little bit of improvement can be seen only if you document daily. So that is very important. Thank you very much for your patient listening, and any input from you will be highly appreciated.
The claps say it all. Believe me, never before I have heard such a lucid talk on infective keratitis. And hats off to you. The confidence with which you spoke shows that so much knowledge you have. And
Thank you,
I think the time you can take more if you want. I can sacrifice my talk, but believe me, this was one of the most illuminating talk.
Thank you, sir.
And that was the whole purpose of session. You have revised Smolin partly for us, or those small tips, even a retina guy can understand.
Thank you, sir.
Yes, any comment?
Yeah.
I appreciate all the pictures you have presented, but generally what we come across are the patients who present late, ill-managed, and you can't differentiate from any kind of pathologies there. Only thing I have been able to differentiate sometimes is early viral ulcers, where dendritic patterns are seen. rest, they keep on deteriorating. Finally, you keep on treating with fortified amikacin and all, cefazolin, and even give all the types of therapy like fluconazole also, then retamicin also, but they keep on deteriorating, and finally endophthalmitis, clear up the vitreous, and then also the cornea is melting and intrastromal amphotericin B, and still the patient does not get relief. So you have any comments to make about
Yeah.
the frequent presentation in our centers?
See, I mean, these things can happen, but I would say that we should not believe in cocktail therapy. We should have one direction. And if the patient has come to you very late and you're not very clear about the, you're not getting a proper diagnostic clue from the picture, then you have to do scraping. And as I said, there are two things that can be done. One is gram staining that will give you immediate result, and the other thing is KOH. And just listen to me first. And KOH is very important tool because it's not correct to keep giving everything, because what happens that sometimes if you give too much of antibiotics in cases of fungal keratitis, it will not respond.
You see, I have seen Rajesh, patient carrying a big chitta of
Yeah.
this thing, all the available antibiotics, antifungal, antiviral, all being given. So that cocktail, I don't think so in
Yeah.
clinical medicine is, you see, what happens ultimately, believe me, is that patient is putting more of lubricant drops than, antimicrobial.
Absolutely, and it dilutes everything. It dilutes everything. So we want...
It hurts when, you are talking, bhai, aap kya dawai dal rahe ho? Doctor sahab, main Flogel dal raha hu, main ye dal raha hu. Arey, dawai kya dal rahe ho? So that is the problem of giving, one chitta of, I am talking of big people who 14, 15 medications written down there. So,
Stains also come negative because already so much treatment has been given.
Yeah,
KOH negative, culture negative.
So
proper
that's what
knowledge level.
Rajesh gave a tip where to take the scraping from.
Yeah.
That's very important. With this, I don't think we'll close discussion.
no, we can close the session also, but I will just rush through this.
Dr. Lalit Verma.
The reason we designed this, session was about TIPS. I said in the beginning, it's the practical tips which we want to discuss. Maybe we want to learn also and offer some tips also. Aim is to share. You see, everyone will have some tip to offer. Aim ultimately is to, improve our practices and benefit to the patient. I'll not discuss about endophthalmitis in detail, but believe me, it's a disaster. Rajesh, today I learned that, I thought only endophthalmitis is an emergency and CRAO is the emergency, but today you taught that infective keratitis also is an emergency situation. But the issue in endophthalmitis is if not managed in time and properly also, a lot of people keep giving topical drops, subconjunctival injections repeatedly, and result can be this, and result can be this, which is phthisis bulbi. This is what we don't want. And the whole purpose of this session is tips. And believe me, if you are an operating surgeon, the shadow surgeons are there, they keep smiling every time. But it is the operating surgeon where the smile goes down, and my family, once over I see endophthalmitis, my entire family will know kuch gadbad ho gaya aaj, and why is the mood so unhappy. So we all know intravitreal antibiotics is the mainstay. Results are very good if you, inject early, and provided you are lucky that organisms are sensitive. Punita was telling about sensitivity and cocktail kind of treatment, but organisms has to be sensitive to whatever you are doing. If not, then, vitrectomy is the ultimate answer. But before we go for prompt treatment, the aim is to diagnose it very early. You see, you have to diagnose very early so as to, because treatment we know, either it is intravitreal antibiotics or vitrectomy. But diagnosis is what is often delayed. And this delay is despite, we having pre-op measures, per-op measures, betadine. We used drapes to isolate lashes. Good wound construction is one thing. And a lot of people, today morning we are having discussion about the role of intracameral antibiotics. Cefuroxime, vancomycin, latest is moxiflox. But despite all this, believe me, management of endophthalmitis depends on early this thing. So therefore, I have in this 10 tips for management. First point is to differentiate from the task. Second point is prompt injection. And third is do not delay vitrectomy also. Documentation is important primarily because to save you in the court of law. Court of law does not say that every patient has to improve. Court of law just says that you have managed it appropriately. That's all. Patient may still have thyroid bulbi, but if you have given the intravenous antibiotics, no court can sue you, believe me. But you have to document. You have to write it down, intravenous vancomycin given. Post-op day 1, seen this thing. If you have followed a protocol, believe me, no judge can sue you. But the key issues always are delay. People keep delaying. People keep thinking this is reaction only. They load with steroids. A lot of people are egoistic about telling no follow-up surgery. I heard this dialogue that cataract surgery karaya, but no follow-up is not required. If you have problem, then you come. But believe me, follow-ups are required for initial few days. One delay is of diagnosis because we have to differentiate why is the patient having reaction. Second delay is not giving intravitreal treatment. So rather than following up with drops or subconjunctive injections, you have to give injection at the site. That is what we learned. I was just talking to one gentleman in one of the sessions. He said there is subretinal abscess. Subretinal abscess. So I told him, you go with the 42 gauge needle and go in behind the retina also. So because targeted therapy is the need of the hour in this. Because no amount of oral antibiotics or IV will reach vitreous in a sufficient concentration. Like this patient was treated as inflammation because of this multiple KPs here, but turned out to be infection, and ultimately we had to do vitrectomy in this. This patient, young lady, operated RK a long time back, had a cataract surgery and was rushed for an emergency kind of vitrectomy. But this patient turned out to be pure inflammation and no infection at all. And the way we manage, I'll just let you know. So why we should differentiate sterile versus infection? Because both of them are different entities. One requires loading with steroids, the other requires intraocular antibiotics. And TAS, we all know its history, how it was described. I personally think every patient who undergoes cataract surgery has some amount of reaction, which is some amount of TAS is definitely there. Because all this, whatsoever you put inside the eye, some inflammation will definitely be there. But mild patients of TAS, they improve with routine treatment. All of us give antibiotic-steroid combination. These patients improve. But finding a etiological factor in a patient of severe TAS is a challenge because there are so many of them. A year back, AIOC received complaints from nationwide, virtually epidemic. So many patients were reported with TAS, but believe me, ultimately could not isolate what's the wrong. Although one particular IUL was blamed, but that IUL also we could not finally conclude. So there's so many causes of TAS, including endotoxin, residue, hand pieces, sterilization, talc, cottonify, so many things are there. All irrigating solutions. Even this prophylactic moxifloxacin which you inject, that also can induce TAS. I was talking to Dr. Rajesh Fogla. He said, you see, don't depend too much on intracameral moxiflox because there's a referral of toxic reaction in the endothelium are also pretty high. What is important is TAS develops very early. So next day, patient will have limbus to limbus corneal edema. So this is a patient of TAS. Whereas in infection endophthalmitis, unless it is fusarium or unless it's pseudomonas, will take 1 or 3 days to develop. But if it is within 12 hours and there's a limbus to limbus corneal edema, suspect TAS. The other point is in a patient of endophthalmitis, because of this cyclitis element, IOP is never high. IOP is generally normal or low. But in TAS, it may be raised also. So this patient I had shown in the beginning, the reason I loaded this patient with steroids was that there was this corneal edema, and we kept this patient in our outpatient department. And ultimately, this patient started showing some glow here. We documented, and then no intravenous antibiotics were given. Ultimately, after 2 weeks, this patient improved. This is the story of that young lady which I told operated RK and then very severe corneal edema. The thing which tilted my diagnosis was this whitish color of the vitreous opacity. if it is an endophthalmitis, generally color will not be whitish. It will be a creamish or yellowish kind of color. So this I thought was an eventful surgery with some lens droppings. So we loaded this patient with intensive steroids by all the possible routes. In fact, intravenous 2 cc Decadron also we injected. And you see how much this patient improved slowly, this edema went away, pupils started dilating, and you have this lens matter which also got dissolved, and ultimately patient had good vision. So all these patients who rush to you for vitrectomy, you should take your time, evaluate, and then take a decision. Endophthalmitis, we all know, has to have vitreous exudates. Definition of endophthalmitis, apart from inflammation, it has to have exudation into the vitreous cavity. And exudation takes time. You see, if you do ultrasound in a fresh patient, maybe anechoic also. Because this clump of opacity is, there is a minimal, 0.5 millimeter or so clump to form, then only will throw a signal. And organisms grown, we all know, but organisms in our country, I think, are more of gram-negative and fungi compared to what EVS had reported. So we have to be very particular about this, that fungi are more common in our country and gram-negative also. Signs and symptoms, these are listed, we keep tabulating. In a patient who has sterile reaction or inflammation, the vision drop will not be marked. If it's a marked visual drop, then you have to suspect infection. And PR inaccuracy also should tilt towards infection. Hypopyon can occur in both, actually. If it's a very severe TAS, hypopyon can occur in both. But pain and lid edema is severe in infection, but not in TAS. Similarly, as I said, color of exudates is generally whitish hair and yellowish. IOP generally low in infection and normal or raised hair. Then endophthalmitis will generally have a focal infiltrate from where the organisms have had ingress into the intraocular cavity. Fundus glow, again, if you can see the retina reasonably well, possibility of it is TAS is high rather than infection. So this tabulation we did a long time back, which can help you to tilt diagnosis in a patient who does not have all the telltale signs. So often patients may be in gray zone, whether it's TAS or infection. But what is important is unusual patient pain. You see, patient enters your OPD and he is having hand here, pain बहुत ज़्यादा है डॉक्टर साहब. Or patient was doing well, say for first day, second day, but second day patient, third day patient has a drop in vision. So decreased vision after the gain, which does not happen in TAS. This happens in infection. Or patient has a lid edema and chemosis. Lid edema and chemosis also are signs of infection. You will not find a patient of TAS who will have lid edema or chemosis. Then corneal hypopyon, as I said, I have seen patients of TAS with hypopyon. But most important is, obviously, if there's an exudation in the vitreous cavity, that is 100%. But even then, if you can't, then always are on the side of infection. You will never regret giving intraocular antibiotics, but you will regret not giving intraocular antibiotics. So this I said, although all surgeons have their own gold standard because surgeon knows how much trauma has he caused. So I will ask patient, surgery mein time kitna laga? Because if the time taken is routine 5-10 minutes, it's okay. But if the surgeon has taken half an hour, 45 minutes in today's era, then something has gone wrong during surgery. So increasing pain, increasing reaction on the first post-op day, and decrease in vision after few days. So gain after dropping vision, vision going down after the initial gain is a sign for pain. Again, is not 100%, but 25% patient may not have, because fungi are known to be silent, where signs are more than symptoms. Patient may not have much pain. From the science point of view, always my OPD will start with distant direct, because distant direct gives you wealth of information if the glow is obscured or not. And secondly is the exudates in the vitreous cavity. So if there is a hypopyon and vitreous exudates, you are dealing with short endophthalmitis. This is short. But what if you can't see the vitreous? Often it is obscured. So what we pay attention is to these three things. What is the vision of the patient? How much you can dilate the pupil and see the wound margin. So based on these 3-4 things, maybe you can make So if the exudates are there and diagnosis is confirmed, if no and pupil does not dilate, we see the AC reaction. If it is a marked AC reaction, lot of cells, says 3, 4 plus, and vision is also down, then in such patient we will advocate injection. However, the vision is good and AC reaction is also mild, maybe this will tilt towards TAS. So that is, it's a dynamic thing that you have to evaluate patient repeatedly also. So key issues are delay and delay. We should, therefore diagnose it pretty early so as that optimal treatment can be given appropriately. So we'll not go into the management at all. So aim was to, give some tips in diagnosis of postoperative endophthalmitis. So this slides again, last slide comes again, that these are the few tips for approaching a patient of endophthalmitis. Thank you very much for your kind attention.
Thank you, sir, for wonderful presentation. I mean, we would love to, listen some tips regarding management of endophthalmitis also.
No tips. I think this talk was basically focused on diagnosis. But you see, early, I would advocate that all surgeons, irrespective of their specialty, should learn that technique of giving antibiotic injection. And the dosing and all are all available. But those intravitreal chart, which I had distributed 2-3 times, and courtesy Sipla, who helped me to, make this chart and post it to all. This chart should be stuck onto the OT wall. Prepare the drugs yourself, avoid dilution errors, and take it as a serious intraocular procedure. And most of the times we do under topical. And as I said, if the organisms are sensitive and the response to intral antibiotics is very, very good. There should be no delay, because I remember one patient I operated just prior to a holy day, and next day happened to be a holiday. So went to see that patient had endophthalmitis. So had to open the entire OT and give it on the same day. You can't delay, you can't ask him to come on Monday. I still remember I went to Gurgaon, it was a Saturday, so had to do it on the same day.
So along with intravitreal injections, do you also give intracameral in some cases? Or
you can, because if the load of the infection is very high and AC is full of exudates, then yes. But by and large, intravitreal only, unless the AC is full of exudates, then I may. I do not mind overloading with antibiotics. I don't think so. They are so toxic to the retina. Aim is to save the eye and kill the microorganisms. So I will, you are right, that give some part in the AC also. Because in any case, you see, once you are giving two antibiotics, you have to decompress. And the best way to decompress, apart from biopsy, is AC paracentesis. So at that time, you can give.
Suspected TAS or endophthalmitis.
Yes.
Actually, I have patients who develop vitritis after 15 days.
After?
15 days.
Of cataract surgery?
Cataract surgery. It's only vitritis, this visible macula is also grade 2 types of vitritis. I was started steroid. After 10 days, vitritis resolved. But again, after stopping, after tapering the steroid, to lower it 20 mg or 10 mg, patient again develop vitritis again. It is what I have to suspect. It is TAS or endo.
So most likely it is a low-grade endo. Low-grade endo, because all eye tests will respond to steroids. You see, remember, endophthalmitis also has inflammation. It's inflammation plus infection. So if you give steroids, inflammation part will come down, you will have some improvement, especially in your patient where there's only vitritis. So you give steroid, but vitritis is an anatomical diagnosis. It's not a short etiological diagnosis. So if a patient is repeatedly having infection, you should do a vitreous biopsy and tap to find out. A lot of times you may become wiser. But if the patient is, recurring after you are tapering the steroids, you should rule out infection, because most likely it's a low-grade infection which is causing an issue. What I would do is I will do during the vitreous biopsy or taking a tap from the vitreous, do a vitrectomy also, and at the end of vitrectomy inject antibiotic. So most of the times we are still persisting in low grade, we still persist with the Vanco and Kefta. Unless it's a virulent organism, then we go to tazobactam and piperacillin.
One thing what I'll like to reiterate, that the diagnosis is key. And I can tell you, if you diagnose and inject at a proper time, 85% of the patient will return to 6/6 vision. Only 10 to 15% patient undergoes worsening and further vitreous surgery. And if you diagnose, there is a thing what we call as a minimal inhibitory concentration. If the eye is full of exudate, then no intravitreal will work. If the load is less, then only the intravitreal antibiotics will work. So diagnose and give it, and 85% to 90% of the patient, you will be able to salvage the eye.
So if the load is very high, then I start preparing mentally the patient for vitrectomy also. I may give intravitreal, but I start preparing. I tell him that the amount of load is so high that you have to, it's like an IND, you have to take out this bulk. And then the antibiotic penetration, the response also will improve. If you allow this so much of bacteria and exudation inside and give intravitreal, it may not work. So like Vrinder was saying, you have to debulk, inject antibiotics, and sometimes silicone oil also, depending on whether the retinal surface is loaded with exudates or not. If the exudates are on the retinal surface till the ora serrata, then ultimately I inject silicone oil also. The advantage of having silicone oil after a radical vitrectomy is that silicone oil per se that you inject 4 cc or 3 cc is impervious to any kind of microorganism. So what is there? Here is the retina. So this small space between the oil and the retina you can take care of by intravenous antibiotic or oral. Whereas space in front of the iris you can load with topical, what Rajesh told, concentrated drops of, Cepha and Toba or Amica, that will take care.
Finally, the antibiotic has to work. If the antibiotic does not work, you can't cure with vitreous surgery. Even one bacteria can grow over a period of time and cause a lot of exudation. So you have to find the sensitivity, and antibiotic has to work to get a good result in any of the case of endophthalmitis.
Yeah, yes.
Do you do both ACTAP and vitreous biopsy? And if you do vitreous biopsy, do you use a 25 gauge?
Yeah, so I don't do both actually. If I am doing a vitreous biopsy, I do not do AC tap at that time, because the only reason I said vitreous tap is, AC tap is because people who are not well versed with the vitreous biopsy, because I don't advocate putting a needle inside and sucking the vitreous. That is not good. So vitreous aspiration is out, vitreous biopsy is in. Vitreous biopsy, other advantage is the yield of microorganisms is higher than doing an AC analysis. The AC problem with AC is that the microbial yield is less. Vitreous biopsy, the possibility of growing any organism by culture is higher compared to an AC tap. AC tap we advocate only for people who are not very well versed with the antibiotic, but you have to decompress the globe, because you can't inject 2 or maybe 3 antibiotics without decompressing. Otherwise, the CRA is at risk, central retinal artery is at risk. So vitreous biopsy is the choice, there's no doubt.
With this,
But it's very rare that you will have different organisms from vitreous and AC.
With this, if the audience does not have any question, we'd like to close the session. We'd like to thank Dr. Lalit Verma, Dr. Harbans Lal, the Doyens of Ophthalmology, and Dr. Rajesh Sinha for giving us vital tips in day-to-day practice, how to manage it. And it's basically practical tips which works in your day-to-day practice. Thank you very much for staying with us.
Just wanted to inform everyone that, this term, as I was mentioning earlier, once we were sitting and Lalit sir only coined this term tips, that is tip in practice. So what exactly we need in practice, that we should know. So that's how we have been doing this session earlier also. And it's wonderful to have tips from people like him, from Amrinder and everyone. So thank you very much for being a part of it and giving your inputs and feedbacks.